this is my disclosure. What I want to do is to think about, when we look at health economics, is it relevant to HE? If it is relevant to HE, what health economic evaluation should we carry out within clinical trials, and how should we go about doing these evaluations? I've done a very kind of basic introduction to types of health economic evaluation, and there's several different types, but relevant to kind of clinical trials, there's two main ones. So the first is cost effectiveness analysis, and this is where you look at natural outcome units, which could be life years gained, could be the amount of blood pressure reduction with an antihypertensive, could be prevention of overt encephalopathy. And it means that you can compare different treatment models, but within one specific clinical group. So that's fine for kind of case level decisions, and you know, from a clinician point of view of looking at the difference between different interventions for the same indication. However, if you want to compare indications or you want to compare treatment models across the whole system, we use cost utility analyses, and this is where they use a quality adjusted life year as the outcome. So this would be used by strategic health bodies, commissioning groups, the Department of Health, or the FDA. I thought it'd be useful to kind of remind ourselves of what we're actually trying to do with cost effectiveness analyses is really quite straightforward. You know, it's really quite a simple thing to start off with. So if we kind of plot the efficacy of two treatments, so if you've got the new treatment being number one, the new treatment being number two, the old treatment being number one, you can plot the efficacy across the x-axis. So on the left-hand side, the new treatment is less efficacious than the old treatment, and obviously on the right-hand side, it's the new treatment that's more efficacious. And then cost on the y-axis with the top of the line where the new treatment is more expensive than the old treatment, and vice versa at the bottom. So we end up with four quadrants where the new treatment would be less effective and more costly. Bottom left would have the new treatment being less effective but less costly, and then new treatment more effective and also less costly. And the top right, the new treatment is more effective, but it's also more costly. Now, clearly, when you're evaluating the prospects for treatment two, well, if it's less effective and also more costly, it's not going to be attractive proposition. Clearly, if it's more effective and actually costs less, then we don't need to think too hard about whether we're going to adopt it. But clearly, the other two quadrants are less straightforward, and so if we've got X where it's very much cheaper than the old treatment but slightly less efficacious, that might be a desirable thing, a desirable place to be, rather than a treatment that's much more, just slightly cheaper but much less efficacious. In reality, most treatments end up in the top right, where they're more effective but also more costly, and so the purpose of cost effectiveness analysis is to look at whether the kind of payoff there, whether a new treatment is is considered worth the extra cost. So yeah, how much are we prepared to pay to achieve these better outcomes if it's more efficacious but more costly, or how much would we be prepared to sacrifice in terms of outcome to save any extra resources? So then when we go and look at cost utility analysis, it's then comparing different conditions and looking at health related quality of life as one of the inputs to that. So if you measure health related quality of life from a scale at the bottom where you're dead, at the top where perfect health is at the top of the scale, and then health utilities do that and put it on a 0 to 1 scale, that becomes a health utility. If we then plot the disease course in years, then the area under the curve becomes quality adjusted life years. So cost utility analysis use these QALYs as measures, and then if you're comparing two different treatments, then you can see that if the new treatment leads to a gain in quality adjusted life years. The difficulties come when we look at how we derive these health utilities. So the kind of traditional or direct methods are things like time trade-off, standard gamble, and these could either be derived by patients, but they're sometimes also derived by members of the public. And the kind of arguments for doing that are that sometimes it's argued that they're less subjective if you get members of the public to do it rather than people who actually have the condition itself. But these direct methods are quite time consuming and tend to need specially trained personnel to carry out the derivation. So we've got indirect methods which are always patient derived, and these are derived through kind of questionnaire based instruments. So the three common ones, and these are generic instruments, so they can be used in any disease. Three common ones are Health Utilities Index, EQ5D, which and SF6D, which the SF6D can be derived from SF36, which is the largest kind of generic quality of life measure. There are also some disease-specific instruments, but these aren't really particularly well established. So I wanted to give an example relevant to HE. And so this is using the example of rifaximin and our experience in the UK. So it's recently been through an appraisal, technology appraisal, by the National Institute of Clinical Excellence, or NICE. This is a body in the UK that makes decisions about whether treatments and other health technologies are considered cost effective, and they use health utility analyses to come to these decisions, and they have a threshold of £30,000 per quality adjusted life year, above which a treatment would not be considered cost effective. In the initial submission that was made to NICE as part of this rifaximin appraisal, so they took the first approach, the approach with the direct derivation of utilities using time trade-off and standard gamble techniques, and that was derived from 200 members of the public. So they described to the public what a con score of 2 would be like, a con score of 3, and for each of the 5 con scores, they were able to kind of the public would respond as to how they would feel if they were in that condition, and they were then able to derive these utility scores. I just put the figures there because I think it highlights how variable some of the different methodologies are. So for example, with con score 3, time trade-off gave a health utility of 0.7, whereas a standard gamble it was 0.5. So really quite a big difference, particularly considering it's just on a 0 to 1 scale. So that data was initially presented to NICE, and NICE came back and said that they had reservations because it was derived from a non-patient population, and also that there was some data already available from the randomised controlled trial. So the randomised controlled trial that was published in the New England Journal, which had shown that rifaximin had clinical efficacy. So had a hazard ratio of 0.4 when compared to placebo in combination with lactulose. And within that trial there was also some health-related quality of life data collected. So CLDQ, which is the chronic liver disease questionnaire, was completed every 28 days for the patients within the trial. This quality of life data was presented separately in Sanyal paper in AP&T, and the data was presented as a time-weighted average. So in other words, the kind of contribution, the kind of area under the curve for the 6 months of the study. There was also SF36 data, but that hadn't been previously published. So NICE had said, well, if you've got this quality of life data, can you not use that to make a more accurate assessment of health utilities? So the quality of life data from that randomised controlled trial showed a clear benefit, a clear quality of life benefit in all 6 domains of the CLDQ tool. So these are the 6 domains here, and there's also an overall score at the bottom. So I suppose it's tempting then to say, well, can you derive health utilities from the CLDQ? And there's no established technique for doing that. So there was some work done looking at how it correlated with EQ5D scores, and they found that they were able to predict EQ5D scores pretty well from CLDQ. So a submission was made, resubmission was made to NICE, looking at using the CLDQ data to derive health utilities. The response was then that the methodology used to estimate the utilities was not appropriate because it was a new method. It wasn't an established method to convert CLDQ into utilities, and because there was SF36 data there, could it not have been just derived directly from that SF36 data rather than the CLDQ stuff? They also said, well, patients were unable to rate their health during an overt episode, and so the data only reflected the remission period. They said it would be useful to have also collected information on the length of hospital stay involved with overt episodes, and to have included that in the cost effectiveness analysis. They felt that the incremental cost effectiveness ratio that was calculated of £20,800 per quality was probably an underestimate. So I think that example and all that information is in the public domain on the NICE website. But I think the example it gives us some areas where to think about in the future in terms of challenges for future trials. Should we be evaluating health economics alongside trials of efficacy? And I think in this kind of cash conscious time, we probably should be doing that. It's not enough to show that treatments are efficacious. We also need to be showing that they're cost effective. So if we're going to do that, how do we derive these utilities? Patient-derived methods are likely to be more acceptable than methods deriving it from the general public. Direct methods are consuming and much more difficult to repeat on a longitudinal basis. So probably using these indirect methods, so the preference instruments with usually questionnaire-based ones, they're simple to implement, and you can repeat them at various time points across the trial to see the effect longitudinally. Looking specifically at health utilities in HE, well, there's not much published in this area, apart from the utility scores that I showed that have been derived from the non-patient population. But if we look at hepatocellular carcinoma, we know that the various different methods give, again, the patient-derived methods give really quite varying results, and you can see the health utilities index and the EQ5D there as well. We know that the sensitivity of health-related quality of life tools varies. I think another important point to think about is when do we measure the health utilities? Because if we've got a disease that's got a kind of fluctuant disease course, with kind of illustrated 2 overt episodes there. If you're measuring the health utilities or you're not measuring the health utilities when they're in an overt episode, you're going to hugely overestimate their, the impact of the disease on the quality of life. So looking more widely, it's not just how we derive the utility measures, but just looking at the cost of HE in general. This is some work that we did with Craig Curry's group in health economics and epidemiology in Cardiff. And this was a study that we used, the CPRD, which is the Clinical Practice Research Database, which has about 10% of all the UK primary care records. And we compared HE patients with cirrhotic controls, so matched cirrhotic controls. And we found that the HE patients were admitted to hospital 3.6 times more than the controls. the length of stay was slightly longer, and they were more likely to have emergency admissions. So 62% of those admissions were emergencies versus 50% in the non-HE controls. They also saw their GPs in primary care much more frequently, so 18 times a year rather than just about 9 times a year. As well, putting HE treatments in context then I think is important. If we know that the resource use with HE patients is significantly higher, and this is just a small audit that we did looking at our experience in Newcastle of rifaximin, and this was prompted by concerns that had been raised by the trust about how much we were spending on rifaximin and whether we could justify it. And so we looked at hospital admissions in patients pre-rifaximin, so for a period 1 year before they were started on rifaximin, and then a period 1 year after. And we found that the average cost, the mean cost per patient of bed admissions in the year before was just about £10,000. But their admissions after rifaximin, were significantly reduced, so that when you included the rifaximin cost, which we know is quite high, even including that, with that, there was still a net saving in terms of the overall spend of rifaximin and beds, and we were able to kind of justify our use to the trust on that basis. So I think in HE, I think demonstrating the cost effectiveness of new treatments is increasingly important. It's increasingly important in any condition, but particularly in HE. Using an established method to derive health utilities should be considered when designing clinical trials in HE. It doesn't make the trial very much more complicated. It doesn't add to the cost, but it might just affect whether the drug can become available in clinical practice in the future. Quantifying the impact of AVERT HE on health utility, quality of life and utilities merits further work. How we measure these things in the AVERT group. We now know that HE is associated with very high healthcare resource use. By accurately kind of measuring these resource uses, we can potentially offset the costs of drugs against reducing the resource use by better controlling HE. Thank you.